Maintenance therapy is certainly an attractive option for many of my patients, but not all of them. I think the big appeal of maintenance therapy is that it ensures that the patients most likely to benefit from subsequent treatment are absolutely going to get it. When we look at who benefits most from second-line therapy, it's the patients who demonstrated a response or at least stable disease to first-line treatment. We also know that some patients who stop treatment and are followed off of it will fall off a cliff with side effects or just be lost to follow-up for whatever reason and miss the opportunity for subsequent benefit. The maintenance therapy trials with several agents, but particularly with pemetrexed and erlotinib and bevacizumab in different permutations, have shown that the agents that are most active as second-line or later treatments can be given earlier or continued from the first-line setting and continue to confer a benefit that is really quite overwhelming in terms of progression-free survival and in several studies also overall survival. So I think that maintenance therapy is very attractive for a motivated patient who is tolerating therapy well. And there are also patients who are really anxious about being off of treatment and feel vulnerable if that happens. So for such patients, maintenance therapy is a beautiful choice, and you can have the confidence that they are minimizing their risk of progression and maximizing their probability of long-term survival. On the other hand, I don't think it's a mandate for every patient. I think it's something that really needs to be individualized for the patient, how they've responded to first-line treatment, how they've tolerated it, and their own preferences. Some patients are crawling to the finish after 4 or 6 cycles of first-line therapy and begging for a break, and other patients are looking for the next thing and absolutely would feel insecure about being off of treatment for more than a few weeks at a time. There's also a middle ground of potentially saying, let's take a month or 6 weeks off and we'll monitor you, and we can either plan to resume treatment or we can watch you very closely and initiate therapy at the first instance of some progression, which may or may not be what qualifies as progression by resistance, by the RECIST criteria. But I really think that this is something that is appropriate to individualize to the patient based on their preferences, their life situation. If they are going back for a family reunion to Hawaii, by all means, I don't think the treatment should interfere with that. But it is the way in many different trials with several different drugs to maximize the benefit and prolong the survival of these patients. And I'll say also that I tend to favor continuation maintenance because we don't have so many effective therapies that we should be in a rush to discard any effective therapy too early. All of these therapies that are effective maintenance therapy strategies lead with pemetrexed, erlotinib, and bevacizumab kind of leading the charge there. They are all typically tolerated well over a sustained period of time, and that's a necessary component of maintenance therapy. If we start with one or more of these in combination in the first-line setting, I'm definitely reluctant to dismiss them just because they were present for a period of time. I think that it really makes sense to wring as much benefit from these as possible until we see clinically significant progression or challenging toxicities emerge, and then move on to the next thing, because we just don't have so many effective choices in our armamentarium that we should relinquish any of them too soon. I would say that maintenance pemetrexed tends to be very well tolerated, but fatigue, sometimes cytopenias, and perhaps a very rare risk of renal insufficiency with patients who are on it for a very long time, which is a luxury, is something to consider. But it's really something that you just monitor the patients and understand that if you need to take a break or move on to something else, then that's okay. In general, I would say it lends itself very well to cumulative therapy. Bevacizumab also tends to be very well tolerated, but over a prolonged period of treatment, if patients are lucky enough to benefit from it for that long, proteinuria can be an issue. Occasionally thrombotic complications, not typically thrombotic or hemorrhagic, but it's primarily proteinuria. Hypertension is a common issue, but one that's really manageable. And then otherwise, I would say erlotinib tends to be one that has issues of ongoing waxing and waning skin toxicities, nail changes, perinachial infections, things like that, that patients often come to manage effectively as something in the background. Oftentimes, they find each other online and share tips about how to manage these issues, or their doctors might know, or they'll see a dermatologist. But when patients are on these agents and benefiting from them for so long, they tend to be very inclined to put up with at least the minor side effects as long as they're convinced that it's providing a clinically meaningful ongoing benefit for them.